meeting will be webcast for live or subsequent broadcasting via the Council's YouTube site, and that members of the press and public may record and take photographs, except where there are confidential items. And just to remind members that the microphone is at the far end of the room, so if we're addressing the room, we need to bear that in mind. Apologies, can I ask the members and scrutiny officers if they have any apologies? And can I also note that Councillor Islam needs to leave about 11:30.
Apologies.
Okay, that's great. Declaration of interest. Can I ask any members if they have any declarations of interest to make? Okay, thank you for that. So we come on to action notes and matters arising. So can I ask the members if we agree the action notes are an accurate reflection of the meeting? Agree. Thank you. So the matters arising are on page 4, which is the period of poverty and raising period awareness tracking report. We're awaiting a response to the request for further information. On page 6 of the adult social care performance monitoring quarterly 1, information on the preparation for adult aspirations and outcomes questionnaire was circulated on the 14th. We all got that? Yeah, okay, that's great. The performance team will ensure that actual figures in numbers rather than percentage will be referred to in future reports, which I think was a request that was made previously. So can I ask members if this further improvement to performance data is going to be acceptable in regards to the bullet point 3? You accepting that? I hope that came with that. Thank you. Page 10, citizens involvement session, early intervention. We're awaiting the response to the further information that was requested. Do we need time scale for that, Gail, in terms of when we're able to get that? Okay. Okay, thank you for that. So the first item today is a report from Forward Thinking Birmingham.
Could I
Of course, yeah.
dive in, Chairman, if I may? The last item that Councillor Pocock chaired was an informal meeting with the CCG, and we were promised the circulation of all the presentations. I don't know whether it's passed me by, but I do not seem to have had that. I don't know whether other colleagues have.
No, I'll follow.
Could you follow it up? Because there were a couple of points that are important, I think. There was a hell of a lot of very, very important information contained in that, as far as the disposition of all the GPs, nurses and the PAMs, professions allied to medicine, that were at the disposal of the community through the GPs. And implicit in the presentation was that Dr. Finlay died a long, long time ago and ain't going to be resuscitated. And I'm sure that caused me some concern, having built up over a period of time a relationship with the GP, that every time you see somebody, you now have to go through virtually your whole life history medically to reach a point where you can be diagnosed. So I would be grateful if we could pursue that and try and get the presentation. As I say, there were some very, very important statistics contained in that presentation.
Before we bring Councillor Pocock in, and that scale, she's going to chase up that and hopefully get a time scale in terms of when we're going to get those details. Councillor Pocock.
Well, just to endorse what Councillor Finlay has said, it was a fascinating session. I know it was in confidence. We got to hear a lot of quite significant and alarming facts about primary care. I noticed on today's agenda there isn't the paper that gives the statistics that we mentioned. So can I suggest, Chair, when we get to that item, that we make a further verbal request for that information and also a timeline for its delivery. If we need to hold a special informal, then we can consider it at that point on the agenda. I think that advise me.
Happy to do that. Anybody else? Read what the Councillor Pocock said. Thank you. Okay, so go back to the agenda. So it's number 5, which is Ford report from Ford Peak in Birmingham, and we have Elaine Kerwin and Joe Conn presenting.
Thanks for inviting us back this morning. We've got some slides. Would you mind just loading those up? And then we've got an opportunity for discussion and questions that you might have at the end. So I'm Jo Carney, I'm the Director of Joint Commissioning at Birmingham Solihull CCG, and here with colleague from Ford in Birmingham. Yeah, hello everybody. I'm Elaine Cohen, I'm the Deputy Chief Nurse at Birmingham and Children's Hospital, and I look after the mental health services here in Birmingham.
Good morning, everyone. My name is Untitled Chapter. I'm a psychiatrist and also the director of the mental health services at Birmingham Children's Hospital, which includes all. Thank you very much for the invitation to this.
Okay, thank you. While we're just waiting for those slides to load, I'll just make a start and start taking you through the context. So what we wanted to talk to you about today is really how we've been planning in terms of understanding both the local and the national context around the impact on mental health, particularly related to the pandemic. So next slide, please. Sorry, this is related to the okay, I'll keep talking. So basically, in terms of what we know, both nationally, the Centre for Mental Health has predicted an increase in demand for mental health services by about 500,000 nationally. We know that we've got the increased fiscal challenge in terms of ongoing unemployment and the economic downturn. And we know that 79% of people have reported that their mental health has worsened during the pandemic, with over 50% of people reporting less healthy eating, less exercise, an increase in smoking, drinking and drug use. In terms of what we're seeing locally, so here in Birmingham, we're seeing an increase in acuity, so a 3 times higher use of our intensive care beds for psychiatric use. We've seen an increase in terms of the complexity of clients presenting, particularly through psychological pathways, and we know that we've got at least 4,000 families in temporary accommodation. We've seen an increase in self-harm of young people, and we know that West Midlands Police are reporting unprecedented levels in terms of increases of domestic violence and child abuse. Would you go to the next slide, please? So in terms of our mental health system collaborative working, we know that health plays a part in terms of the system that supports individuals and citizens in terms of their mental health. And we work very, very closely through our governance and through our partnership arrangements with both Birmingham City Council, the Children's Trust to support children with social care needs, with Birmingham and Solihull Mental Health Foundation Trust, with community services, and of course with our third sector organisations and also West Midlands Police as well. Next slide, please. This slide is a bit of a busy slide, but it basically tries to set out how we've been planning for what we knew was going to be the fourth wave, which was going to be that impact on individuals and children and young people's mental health. So we've been planning alongside the pandemic waves in terms of thinking about how we're going to support access and have appropriate services in place for those children and young people that are coming through with increasing mental health needs. And over to Elaine. Next slide, please.
So in the context of what Jo has reported, I just wanted to talk a little bit about the mental health services enhanced governance and quality assurance that we're undertaking. So clearly with the backdrop of things changing, transitioning and adjustments being made across many services, many organisations across Birmingham, we've been making sure that we've got really good oversight of patient safety and really good oversight of the quality of services. So that includes making sure that we get really good feedback from our service users, that we get professionals' feedback, and we are always using that feedback to make sure that we're improving the service. We've had some challenges in the context of we were one of the only mental health services nationally that remained open throughout the entire pandemic. The only service that we had to adapt was our pause drop-in centre at Digbeth, which went online. But other than that, every single service remained open. And we continued with some of those challenges, making sure that young people weren't falling through the gaps, making sure that we could still manage those referrals. And as part of that, also, there are some system changes, and you will know about the integrated care system approach for Birmingham, and making sure that anything that we do is associated and aligned with what's happening in other systems. So we want to make sure that we've got that systems approach and that reporting, which from my perspective makes sure that I've got a really good line of sight. Our medical director has got a really good line of sight, right from the community to the ward to the board. And that oversight has increased. We've got internal meetings that happen on a weekly basis. They feed into our monthly meetings, and then closely working with our commissioner colleagues around the system work. Next slide, please. I'm going to pass you over to Dr. Dharma, really just to talk about our transition around recovery and our current performance. We're going to talk a little bit around the demand that is in the system, and that includes the referrals into our service and the types of referrals that we're seeing for children, young people and young adults, both who we're looking after in the community and those that we're looking after on our psychiatric inpatient units as well.
Thank you very much for that, Elaine. The next slide, please. So what I'm going to do is to sort of just explain a little bit more about the points which Joe and Elaine were making earlier about the demand and capacity within the system. So, I mean, initially at the start of the pandemic last year, what we saw was that there was a decrease in the number of referrals coming to FTB for a bit of time, which was quite in line with what we had actually seen happening in the system regionally as well as nationally. Because of lockdown restrictions and other factors, people were unwilling to sort of come into and access at the start of the pandemic, which has, I mean, it was concerning at the time because we knew that that was just a pent-up demand, and that demand would sort of come into the system down the line, which is what we have actually experienced over the course of the last 12 months. So if we sort of compare our referrals that we have received into FTB in the past few months with the referrals that we received over the past few years, like for the same period, we have seen about sort of 25 to 30% increase in the number of referrals coming into FTB. And I think it's really important to highlight that pandemic. I mean, we all know about the impact of pandemic on our population in general, but the impact has been equal. So there has been some specific sections of the society, some individuals have been more vulnerable through the pandemic and have been affected disproportionately because of the impact of various of the health impact as well as the socio-economic factors. And we have seen that variation in the way that people have accessed or tried to access health during this period. So we have been very mindful that the recovery work and restoration work needs to focus on making sure that people who have not been able to access health are sort of given appropriate attention, and efforts are made to reach out to those sections of the society. I think it's important to just highlight again as what we have seen presentation-wise in the system. There's been increasing acuity of mental health presentation over this time. Again, some of this sort of goes back to the period when we saw a reduction in the number of referrals, and that pent-up demand has sort of has translated into people developing more acute mental health issues. We've seen increasing young people presenting with psychotic disorders. Locally, there have been very high demand for urgent care services. There's been an increase in self-harming behaviors, increasing substance misuse, domestic violence, and trauma-related presentation. So what we have tried to do is, obviously the Access Center, what we call referral management center, which is the front end of our mental health services. We have been doing quite a bit of work in our referral management center to ensure that people coming into the system, that those referrals are triaged as soon as possible. We had sort of seen a delay in those triages because of increase in our demand, but we have sort of cleared quite a lot of that over the course of the last few months. We are doing quite a bit of work in our primary care colleagues, because we need a system-wide, whole system approach to dealing with this increasing demand. And we know that, we cannot sort of do this in isolation ourselves. So we have been sort of working on those relationships, which Elaine and Joe referred to as well as part of the ICS work and as part of our community mental health transformation. So I'm just going to hand over to Elaine now, because there's quite a specific response that we've been working on, so she will sort of go through that.
Yeah, and really just to give you a flavour of the kind of numbers that we're seeing. So on average, we're seeing around 100 referrals a day into our referral management centre, and around 2,000 calls from families per month. So what that tells us is that the service is being accessed. What we predicted is true, that there would be more children, young people coming forward and families requiring help. And at the moment, what we predicted in terms of the surge is generally accurate. So our intelligence and surveillance is working. That's not to say that we're not going to see other challenges as that number increases. So I'm going to tell you a little bit about what our response is and what we're changing, and the opportunities that we've had really in terms of some of the major system projects that we've been developing with partners. Some are around the table here around some of the new services that we've expanded and we've been developing. So our inpatient services for children and young people under the age of 18. We have a site at Moseley Parkview Clinic. It's under modernisation. We're looking at some additional beds to build capacity. And the workforce developments around that have been pretty successful. That work will start in the next few months and it's due to be completed next year, but that will give us a new ward, it will give us a new building and the implementation of obviously some new beds in the system. The implementation of the West Midlands Cancer Provider Collaborative, what that means is that Birmingham will have more oversight and we'll work together with partners to bring children and young people closer to home in terms of their care for inpatient services. We know that that has been an issue, and I personally have received and had many conversations with our families around their young person going out of area because there aren't local beds. So we're working on a programme to make sure that we can improve that, not just for Birmingham, but across the West Midlands. One of the areas that we have been successful in and we're really proud of is our implementation of our charity-funded peer support workers. So that is a programme for young people who have used our service to come back in a paid position to provide peer support to other young people. It's a whole programme around recovery, training, education and additional support. Those are just some of the major system projects that we're carrying out with partners and contributing to all of the areas that Joe raised concerns around. So making sure that we've got education, we've got employment in there, because those are really important around recovery. Our mental health solutions, so our ability to be able to remain open and functioning, was really helped by our transition from in-person appointments to remote delivery. So online delivery of services went up to about 70%. We had feedback from young people and we did a huge evaluation around what that felt like. It didn't suit everybody. We had feedback that there were gaps, and we have now reviewed that remote delivery. There are more in-person appointments for those that want them, and we still have telemedicine for those that favour that as an approach. Our pause redesign now aligns to the Birmingham Children's Trust Early Help Model, and we've extended our mental health in schools programme. We have looked after 450 schools throughout the pandemic. We had a campaign called #You'veBeenMissed, which was about supporting children and people back into education. It was hailed nationally and talked about in the Houses of Parliament as one of the programmes of work that Birmingham produced, which was enormously successful. So we're really proud of that. And we've increased our level of support available for Birmingham universities. We have had some feedback that those students have been really challenged. We've listened to that feedback and we've improved some services by providing some in-reach services actually into the universities themselves. Our enhanced assessment approach to assessing clinical risks for those who are at most risk, we know about, so we make sure that our crisis team and our 24-hour helpline is always available and is well communicated. And we have had some feedback that perhaps that could have been communicated better than it was, and we hope that our comms and website promotion has been able to allow people to really understand how to get support in the crisis. And it goes without saying, major investment in IT facilities. Our people in our workforce have been really important throughout the pandemic, keeping them well and making sure that they're equipped. We have got some really good developments in the pipeline. So Birmingham and Solihull are moving towards a multi-centre urgent care at the Oliester, which is a joint proposal with Birmingham and Solihull Mental Health Trust. And it's a one-stop shop for urgent and crisis care and psychiatric decision unit that comes on board early next year and will really transform the way that we support our children, young people and adults, all age, in a crisis. Our mental health teams in schools were on wave 6, so you will see how we've expanded that rapidly, and our early help around working with our social care partners, housing, and then our joint partnership with St Basil's, which is a new transitions hub for very vulnerable young people who are vulnerable to losing their accommodation or who have lost their accommodation because of their mental health needs. So that was a bid that we submitted with St Basil's jointly, and we're working with 12 very vulnerable young people at the moment who would be homeless, and they are being accommodated and they're receiving an all-round package of care. Young people leading engagement and co-production. So this is always at the heart of our service, listening to what our children, young people tell us. We did have some feedback, and we worked closely with Health Watch around some experiences that weren't so good, and we've worked with some of those challenges, knowing that we needed to improve some of the services, and the last 12 months has seen us really have an action plan that's improved some of the issues that were raised with us, and that was around access to crisis. It was around being able to not sit on a waiting list, but get help as quickly as possible, for example. And you'll have heard Anna Pam say that our waiting list is the lowest that it has been. Still needs to be lower, but in terms of us being able to bring our waiting list down, we have been successful around that. And then obviously our review of our youth engagement and participation has been really, really crucial to us. So I think the CQC review that took place, Joe's just going to end on that. So this was a review that took place in June and July, and Joe's going to talk a little bit about that, and then we're going to finish. Thank you for questions.
We were invited by the CQC to participate along with 7 of the systems in the UK with a thematic review on the impact of the pandemic on children and people's mental health. And we're really pleased to take part in that at the moment, just to be able to pause and think with our partners and with our service users around what have gone well and what have gone not so well. And I'm pleased to say that there were really good surprises for us. Some of the feedback that we heard were areas that we've identified that we needed to do some work on. One of those has been around the blended approach moving forwards in terms of digital solutions, but also face-to-face appointments for those people that need them. A couple of the areas that the CQC picked up, and I won't go through the whole slide, but they really commended the work that we've been doing with schools in terms of supporting children and young people in educational settings, particularly those at risk of exploitation and where mental health is starting to manifest itself as a symptom. And then the other area was that the caseload, the auditing of caseloads that FTB had done in terms of understanding the impact of the digital solution. So again, some really good positives there in terms of the DNA rates reducing, the were not bought rates reducing. So actually that means that productivity remains high because we don't have wasted appointments. But also that point again that we need a blended approach moving forward to make sure that we're meeting everybody's needs. I think that's at the end there. Thank you very much. Thank you.
Okay, thank you, Elaine. That was really informative. I was really pleased to hear that. Questions? Councillor Pepcock?
Yes, thanks, Chair. First of all, congratulations on keeping going and doing the pandemic, and good to see the service maintained. 3 or 4 questions, if I can, very briefly. Wave 4, there was a bit of backwash from the pandemic up to date. We have a growing infection rate. 49,000 was it yesterday? Do we know whether that carries with it kind of hidden wave 4 plus rolling forward? I know we're told that younger people are predominantly those infected now and that they are less impacted, and that also if you're double vaccinated, the impact of COVID is, when you get it, is less. But do we know what the long run mental health impacts of the current infection are likely to be? Do you have projections for this? Your curve sort of flattened out on your wave 4. I just wondered if there is another bump coming down the track. And number one, so do we know what intelligence have we got about what's coming down the line? Number two, online versus face-to-face challenging. What's the current sort of balance that you feel settling into? Is it sort of 50-50? If you can fill us in on that. You mentioned the work in schools and you're onto wave 6. Would you just like very briefly, what is wave 6? What's going forward for that? And obviously we'll all look forward to getting the CQC report in November. If that can be circulated, we can obviously take our own view on it. Thanks, Jane.
So if we just take the points in turn, in terms of our intelligence and our surveillance, then our work is ongoing there in terms of the family. I think we're becoming much more sophisticated in the tools that we have at our disposal. And recently, an example of that is we've just done some work with the strategy unit, specifically thinking about the health inequality lens and how that impacts on mental health, and how that then impacts again, depending on which community you work with, and some really sophisticated analysis, thinking about how we might need to adopt again, and what some of the ongoing challenges are going to be. That work's ongoing. You know, I don't think we're ever going to be at a point in time where we say, you know, as at today, right, we can foresee, you know, where we're going to be in 12 18, because we know things change, predictions change, and scenarios move on. So I think the point that I'm making is we're getting better in terms of that ongoing predictive analysis, and the way that we're doing that is by making sure that we've got that partnership approach that's really wrapped around it, but we know that it's going to be ongoing long.
Face to face, yes. So we've done calculations, and the way that we've done that is that we've been looking for feedback. We've been looking for feedback from our children, young people, and their families. We've also been looking at the data, so attended appointments versus non-attended appointments, and then looking at our rates of children, young people's experience and satisfaction. So we've settled around a 60-40 ratio. And we're calling it in person rather than face-to-face, because actually it's not all face-to-face that young people want. So a couple of apps that we have been able to evolve and develop with young people. Some young people actually thought that we'd all forgotten how to use the telephone. So going back to some telephone appointments rather than a screen and a Zoom and Microsoft Teams, that actually they wanted to be able to hear their therapist's voice and be able to talk to their therapist over a telephone. And then WhatsApp, and being able to use texting as a form of communication. So that's where we have settled, but it is under constant review. I think our young people's engagement group hold us to account around that through our patient engagement, and we've got a communication group that they lead and support us with. So we are using all of that to continue to review, because it may change again. The group that we found were most vulnerable were around the SEND population, so those with special educational needs and those with a disability or a autism condition. And we've been really thinking hard around our communication around that. Again, some of that was an absolute request to come back to in-person appointments, but there were many families who felt that their family benefited a lot more, and the impact on the overall family by being able to be involved in a telemedicine appointment with everybody there was actually really supportive. We've been able to support, I think we're up to 1,250 professionals on webinars through using online digital, and a lot of those webinars were also very parent focused as well. So we've been able to do a lot of work through that route, but we're absolutely cognizant of the fact that it is not for everybody, and it shouldn't be within a mental health service.
Could just be clear about the figures there, 60-40, 60 in
in person, 40, some in person is telephone, some of it is WhatsApp, some of it is texting. So there are many routes here for young people. I think really what I'm trying to say to you is we have a really good method of getting the feedback so that we know, because that may change. I mean, our increase in referrals mostly has actually been around the younger age group, which we were not surprised about in terms of the return to school, which probably brings me on to mental health in schools, wave 6. So mental health in schools was a Department of Health and Department of Education initiative. It was about aligning to the Green Paper around bringing in-reach mental health and emotional well-being into schools, and joining up with our education colleagues around the promotion of mental health and well-being, but also being able to do early detection, early help and support schools in general. So we were successful with wave 1, so we were one of the first trailblazers. And because we've been so successful, and because Birmingham has implemented it so well, and our pilot and evaluation is about to be released, I'm happy to share that with you. Because we were so successful, they kept coming back and asking us to do more. So we have expanded rapidly, and now we've expanded into 6 pilot sites. So I think we were a team that started out with 6. I think we're now at 33 members of staff within those mental health and schools teams. So we're working with the Birmingham Education Partnership. We're working with our Birmingham City Council colleagues around education, our educational psychologists. We've got an education, emotional, mental health forum that's really well attended. And we use a lot of the information there to kind of really think together with what schools need. Obviously, we're keeping an eye on that, because that is obviously one of the areas that people will know that in the longevity, and thinking about what wave 4 might mean, the impact of lockdown has been most significant, but like Councillor Pocock, we're worried about the cumulative effect, actually. So, you know, we are, for some people it's felt like one big wave, for some it kind of does feel like it's wave 4 hitting us. We've got our public health colleague here, and we're working really closely together actually about looking at what that intelligence and that data means. So Marianne's also part of working with us as well.
Okay, thank you for that. Councillor Tilsley.
Thank you. There's a couple of points that I'd like to raise. You did mention out of area care. I'm not breaking any confidences when I mention that very distressing case from Warsaw that was an out of area placement in Northampton from memory. It had a lot of exposure in the media. I thought it was so distressing that the father involved, I don't know how he got through it, and I don't know how the daughter got through it. And it really does bring it into sharp focus, trying to repatriate into a humane environment, because that certainly wasn't a humane environment or medically acceptable. So, you know, I will always press to have local services for local people as much as possible, instead of people having to travel 50 miles and more. And I know that when there's been some very disturbing mental health cases, that the only beds that have been able to be found have been hundreds of miles away, which is very, very distressing, and it shows the amount of resources that are needed to put into the system. And the other point, it is part and parcel of the Mental Health Trust responsibility. But when I've always raised it with the Mental Health Trust, they've always said it's CCG commissioning. So now I've got a captive audience. It is chronic fatigue syndrome and ME, which really does seem to be the Cinderella of all provision. And I have to say, the provision that is at the Burberry Centre, through personal experience, I know is not fit for purpose. So I'd be grateful if you could take that back and perhaps scratch your heads and look at your budgets and try and find some way of helping what is 250,000 sufferers in the United Kingdom who currently are getting a very poor, if any service at all. Thank you.
Do you want us to, do you want us to respond to?
If you could,
Just,
yeah.
yeah, just very quickly, because I'm conscious of time as well. The points that you're raising, councillor, in terms of out of area, it's always absolutely a last resort for any child or young person to be placed out of area, and the clinical teams work around the clock to try and prevent that. We know it does happen. And we know that we've got children and young people that are placed out of area into acute and psychiatric bed. Part of the work that Elaine referenced there around the development of what's called the larger collaborative, that is a longitudinal piece of work that is all about bringing, to the point that you've made, local services for local people. Bringing services and the footprint and the catchment, the inpatient capacity into a local area, so that young people, they're not travelling the breadth and the depth of the country. You would appreciate that's a really complex piece of work. It's not just about the local services that here in Birmingham as at today. It's also thinking about where those inpatient facilities are. Do we have enough of them? All of the estate capacity that wraps around that. So that's absolutely the strategy that we are working really closely with NHS England on. In terms of the chronic fatigue syndrome, I can't answer that specifically today, but that's something that we'll need to take away and work some more information on.
Thank you.
Thank you for that. We've got a further 4 councillors for one last questions, and we're a little behind in time here, so I'll ask you to be a little bit precise with your questions. So, Councillor Islam.
Thank you, Chair. It's not a question, it is just a comment about the 4,000 families in temporary accommodation in Birmingham, which is actually, yes, I know about it, and because my ward in Newtown, I got 20 high-days plus, and the people are accommodated when they came from abroad, and especially Somali families and other communities. They were actually in 2010, 11, when they had no child, and a temporary accommodation given, 1 or 2 bedroom. Now they have a 5, 6 bedroom, and I have been seeing so many letters from the doctor as a result of because they are waiting to get rehoused, which is very difficult because of there are very limited of housing available. So it is just stress for the families and the children, and also the children are living in 10th floor, 12th floor, there is not where to play, and all this also the children are also affecting. So this is one of the major factors. And so another thing which I can request from you, is there any way can you provide any kind of statistic? I mean, 10 constituencies. So if we can tell you each constituency how many mental health problems, men, women, children, and that would be very helpful for us to understand. Thank you, Chair.
Do you want to comment on that?
No, just absolutely. We are seeing the impact on families who are coming into the city, and those families that have had to make adjustments around their housing and accommodation, and then the impact on children, both around their education and their skills, but also about their emotional well-being. I mean, we are working with both Birmingham City Council and Solihull Council around the InReach teams there, and I was just thinking for a minute about how we could get the figures and the numbers. We've got a psychotherapist who is currently working on a programme with the council, just to kind of think about how we can support those that are impacted, whether it's the individual, whether it's the family, or whether it's supporting the system around that family. I don't have the statistics or the data here, but it is one of the major projects that we are kind of working with our colleagues around.
If you could ask if you could possibly get some of that data for us, that would be really appreciated. If a committee think that would be possible.
Okay.
Okay, thank you.
Yeah.
Councillor Fell.
Thank you, Chair. I'm conscious that time is in essence here. First of all, you mentioned 60-40, and I didn't quite pick up whether that was, you said face-to-face, because I know young people being face-to-face as in person, or it can be via Zoom, so I wasn't quite sure whether that was a mixture, whether it was 60%, 40 and 60 in person.
Sorry if I confused you.
No, no.
So the figure, so the percentage is approximately 60% in
Right.
person. That 60% is made up of actual face-to-face appointments, so
Yeah.
coming into our clinics.
Yeah.
Obviously, we're having to manage infection control situations, and some of that is telephone appointments. So for young people who have smartphones and mobiles, they're very, very agile and don't want to come to our clinics if they're at school or they're at college. And then using WhatsApp and texting as well.
Thank you, that's
All of our staff have work phones. We're all accessible for our young
a
people.
mixture then.
Yeah.
Okay, I was just looking at the engagement and co-production, and I noticed it said the review of the participation and engagement strategy, and I was just wondering whether that was done or ongoing, and likewise with the communication connection group service user review, same thing, whether that was done or ongoing with the website as well, with the FTB rollout, and I'd be interested to know how those updates and reviews are ongoing. Not for today, but I would be interested about the suicide prevention online training tool. That'd be very helpful. And finally, like Councillor Pocock, and this was not a criticism, it was an observation, especially as we have people online and people may be fresh and learning to understand. We had wave 6, but then I noticed as you went through, there was Birmingham, Solihull, ICS, then there was CYP, CAMS, I think it was WM, CPC, STIC, and there was another. That's acronyms for people that are in, shall we use the word, the business, and people probably watching that probably will understand that. But I'm sure there may be new people that say, well, what on earth is STIC? And I always say to people when they put these together, if you can put what it is in the acronym, then you don't have to do it again. They'll understand. But it was an observation. Sounds like strictly, isn't it? But it was an observation, not a criticism. Thank you, Chair.
Thank you. Thank you.
We take all feedback. For the reminder, and yeah, thank you to the people. I think probably, Chair, it's okay with you in terms of the additional information that we can before we go. Just kind of give us a bit of a, I know you're taking notes and word. I'll just note that we don't be making a note as well, but then obviously
Thank you.
just make sure that we're thorough in terms of what we're going.
Thank you for taking that on board.
May I give some very brief feedback? So our patient engagement strategy, we have a beginning of forward thinking Birmingham. It came to an end in 2021, so it's a natural progression into the next stage. It is absolutely led by young people. We've got young people with lived experience in paid roles. They're also leading our campaign, Fight for All the Fields. It's on our website. Our website was designed by young people. It was launched last week. It's got some new resources on it. Young people have designed it, co-produced it with our technicians. And we've also, what we haven't said in the presentation is the carers charter. So we know that families, carers are really important parts of our children and people's lives, and absolutely are often still caring for their young people. So we're just introducing a carers component to our children and young people's strategy as well.
And very quickly, if we could get a link sent to us, so we
It'll be on our
yeah,
website.
then I can
Yeah.
put it onto my folders, so
Excellent.
I can look into it. Thank you.
Thank you for doing that. Councillor Top.
Thank you, Chair. So just very briefly, so I've got quite a lot of questions to ask, but I'm not going to ask all of them. So my question is with regards to the urgent care service that you're going to be providing at the Oliester. From knowledge, I know that the Oliester overall is understaffed and there's been a lot of challenges there. So in line with the increase in referrals that you've made, that you mentioned, and in line with the increase in the infection rate, how do you plan to then manage or have you planned for the staffing of and looking after these patients that will be going to this urgent care service?
Okay, shall I tell that workforce? It's all part of our workforce planning and the workforce assumptions in terms of those joint teams across both thinking Birmingham and Birmingham Sullivan and Foundation Trust. So that there's quite a level of sophistication in terms of the predictions around what roles, where we're going to get them from, retention, recruitment, supply, and we have a specific workforce group that has the remit. We've got support from our HR functions. Both organisations sit on that group so that we plan and work through together what our workforce expansion plans are. And so the urgent care element forms part of that planning work.
And the multi-centre is about co-locating teams that they can work effectively together to support our patients effectively. So in essence, we're not going to be bringing everybody into the urgent care centre because quite a lot of our patients want to be seen in their own homes or they want to be seen out in the community. So the teams will be co-located. There will be one phone number. The teams will all be working together. It's multi-agency, so we will have specialist youth workers, for example, working with some of our youth who not only come with a mental health crisis but may come with other difficulties as well, right through to social work, paramedics, social care, and nurses and psychiatrists as well. So it really is a different perspective about the way that we have been kind of thinking about urgent care, so not just through the lens of the professional, but through the lens of the families who experience that. So from a workforce perspective, we've been doing a lot of planning and thinking outside of the box. I think from a facilities perspective, the urgent care centre will locate the team, but we will still be going out to communities and serving local communities. We won't be bringing everybody back into a environment. Does that help?
So the other thing to quickly add is just to add on to that is follow on from that rather. Attending this urgent care centre, would they then be referred on to further services, further support, following on from that urgent care?
Well, absolutely, yeah. The clinical pathway is about enhancing that first assessment because it's so important for both clinically facing. So it is about getting that first assessment correct and then making sure that that young person is on the correct pathway for their assessment, their care and their treatment. You know, it might be with one of our third sector counselling services, it might be into our early intervention psychosis service, it might be into our eating disorder service, but that assessment is obviously the most important trigger for making sure that our service users get the right treatment and the right intervention. So that's kind of what we're trying to sequence, if you like.
Just what that means that we have also developed lots of mutual aid models of mutual aid working for the past 18 months with learning and social mental health trust as well as with the wider system. So we have got a pathway which supports each other rather than sort of working in isolation as was the case previously. We have got a lot more touch points and working a lot more jointly now. With better funding, which is really helping us keep the pathway running as possible as well as quickly as possible. So in the case of urgent care is that you require the timely assessment and intervention when you are taking a crisis, and our response time times of usually
and the centre has received some additional investment, so it has had additional funding which has supported us around the workforce as well.
Okay, thank you for that. Councillor Clancy.
And thank you. Very informative. Great piece of work that you're doing. Obviously, there's a lot more to do, but it's I commend you for what you are doing because it's thinking your youth meant to be the time of our lives, and really how many are suffering. It's quite shocking, really. And we're there to support them and the stakeholders too. Just trying to think as you were talking about assessments and pathways and how you go about the journey. Do the youngsters have financial support with travel? Paul, Councillor Tilsley talked about local need, local services. Many don't even have bus fare, can't rely on the family for bus fare. And I'm just very interested actually, because when you talk about pathways, just for somebody to think about that journey, let alone get there physically, how do you support in that aspect or not, as the case may be? That's my first point. I suspect, and I don't know, you can answer yes or no to this, that mental health will follow youngsters. And I don't mean in terms of just emotional well-being, but the fact that it's recorded. I'm just interested how they progress further on into other pathways that is not to do with therapy, but work and economic and all that. How do they carry that? I hate to say tag, but I will use that phrase because I'm concerned about how they move forwards with potential employees, having looked at that? Because we all know that we have to fill in a multitude of forms nowadays to say what's happened to us, do we have epilepsy, do we have this, et cetera, et cetera. And I'm concerned that could be a potential holdback for the youth. The answer yes or no to that. It's quite an intense question. My third point is, sorry, very quickly, we've got over 400 schools in the city. You mentioned 33 staff, vet, city council, etc. Do you see that capacity growing?
We hope so.
That's the answer, yes or no?
Yes, yeah, absolutely. We hope we're on way 7, 8, 9, 10. So yeah, that is expanding.
Can I just say just very quickly to that, the mental health support in schools, those teams, that's a national programme. And so as that's expanded, then we will apply through the next phase and the next phase to do that expansion. You can't just roll out to 400 schools at once because because of the pure volume and the work that you need to do, lots of work that you need to do to basically to make that happen. But there is a national ambition that every school in the UK will have a team working.
Right, that's what I meant.
Yeah.
Okay.
First point on the travel. Can it be really blunt? We don't pay bus fares.
I'm just looking at the 60% in-person figures, and I'm thinking 60% for a young person on not any money, especially during COVID, would be quite a stressful situation. And I just wondered if there's any support. I mean, I'm not asking you to say you should support. It's just an observation again.
And I'm not the only person so I was in another meeting with somebody else from the city council in a really senior position. He was referencing a report called Breaking the Barriers and saying, as a city, why are we not taking a position that for the rest of this year, all public transport is free for young people? So you're not you're the second person in a really senior position that have heard make that.
Okay, I know time's an issue because the chair, and that's a debate in a separate forum, no doubt, but I'm talking about specifically for those in this capacity. So you've answered the question, and that's something that perhaps future funding could look at. I'm just concerned about those youths that could potentially miss out on. I'm sure if there are missed appointments or missed parts of the journey, we would look into that, or the therapist would look into that, I don't know, but I'm just thinking of those very simple barriers to why that young person or child can progress. Probably young person, I'm thinking, but that's another.
Yeah, I mean, I'll just on the back of that. I mean, I think where we do know that there are financial difficulties for somebody getting to an appointment, I have to be honest and say, give us the receipts and we'll give you the money out of petty cash. We will reimburse. And we have done that for young people.
Just thinking crisis, I think that's
who haven't. And obviously we can arrange transport for those that absolutely can't get there. But most of our appointments actually are out in the home or out in the school or out in the university. We've got 4 community hubs based all over the city. So we try and make sure that the young person, if they are coming into a clinic, it's the one that's closest to where they live. But a lot of our work now is outreach. It's out in local communities, it's place-based.
Okay, so my third point, I'm going to, because I know Chair's conscious of time, it's really the progression further on into the next stage of their life and how that will, again, not be a barrier.
Yeah, so I think you're talking about stigma, and I think stigma and mental health has always been there. I think the evidence for us about how many young people are now accessing the service and are now asking for help, I think that demonstrates to us that we are breaking through some of those barriers. We're making services more accessible, more understandable. I think the education that we're doing, so the mental health in schools, we're doing a lot of education around what mental health means. We're doing a lot of work with future employers around what mental health means and being mental health aware and being mental health friendly. So I'm not going to pretend that stigma is not an issue. But I'm in my 36th year of mental health nursing, and I would probably say that I've seen that improve. It's still got a way to go.
Just to follow up, so the best advocates for that for the young people themselves, which is why the peer support work in place, employment, that that is the best examples, and that is how you continue to push and you continue to break down the barrier, because there are no better advocates than the people themselves.
And if you go on our website, Forward Thinking Birmingham, you'll see the peer support workers, and you'll get to meet the first peer support workers and hear their stories.
Says in the
time.
title, thinking.
We also work with organisations like Better Pathways, which support individual placement and employment services. So yeah, we have got specific links with them. And as Elaine says, stigma is one of the biggest issues really when it comes to employment. And our links with organisations really help us move things for young people.
Yeah.
Thank you.
Thank you. We want it to be better.
Thank you. Councillor Idris.
Thank you, Chair. Quickly, my question is around people working in care sector and care homes. A tiny minority still refusing to have vaccine jabs. And these are the people who should be promoting the importance of these vaccinations and the impact, positive impact they have in combating COVID. So what are the main apprehensions and how are they being dealt with?
I think, Chair, we need to come back to you on that one, because although whilst we know mental health is everybody's business, we can't answer specific questions about care homes and the vaccination programme. So I think we need to maybe take those to offline and answer those separately, if that's okay.
I think Idris, that may come up in item 7 on the way to vaccination programme, so hopefully that will cover your questions.
Chair, just a quick note if I may. It may be in the total wrong funding part to our guests, but as Councillor Franz was talking about transport, etc., my mind was just thinking the West Midlands Combined Authority, so they have a health board and they also deal with transport. And there may be some connection there with financial help for young people. I don't know, if you don't ask, you don't get, but it may be a different funding budget.
That's a useful way to thank you for raising that. Can I thank the previous presentation? Thank you for really useful, and thank you for the way you've answered the members' questions. It's really appreciate it. Thank you. Bye. You did present the tracking report, and it's committed to enable us to look at the evidence of progress and decide that the cabinet members' assessment is we agree with it or not.
Yes, indeed. I'm not going to read each of the R01. I'm just going to give you the evidence because you've got the report with you. So in terms of the governance arrangements for the infant mortality task force, it's now being agreed with members, member in question and the Director of Public Health, that it will be accountable through the Creating a City Without Inequalities Forum and then through to the Birmingham Health and Wellbeing Board. And the task force will update the ICS Inequalities Board through the ICS with representatives, and the ICS being the new board body that's across the footprints, the integrated care system. And I'm one of the people that will be able to make sure that what we're doing is conveyed to them. Also, the task force will connect with the Child Death Overview Panel through myself and my colleague, but because we job share together, so Dinah and myself will make sure that that takes place. In terms of the establishment of the chair and the task force, we have now got an independent chair. Sushma Akila started on the 23rd of August, and she chaired the first workshop that we had on that topic. We've also, the secretarial support has been agreed for her, and a graduate has been recruited to support the work. We're, the chair is putting together the terms of reference at the moment, so they're in development, and all the representatives that have been identified in the recommendation 1 are being invited.
and the first meeting is expected to take place later this month. The the workshop that we held talked about some of the potential subgroups that will take forward the actions, and those are all being considered in terms of who is going to be the appropriate representation and chair for each of those groups. So that's all in place. So in terms of the assessment that was given that by Councillor Hamilton, she agreed it was assessment level 2, because it's not complete. Then for the second recommendation, in terms of the where we're at within reducing our infant mortality and having a date and target of that. So that we are expected to reduce infant mortality by 25% by 2027 and 50% by 2030. And this is an incredibly ambitious, bold goal, and it is also being incorporated within the draft health and wellbeing strategy that is out for consultation at the moment in terms of creating a bolder, healthier city. At the workshop that was held on the 21st of September, a certain number of outputs was put together, and that's in draft at the moment, and we will be utilising that to inform and deliver the agreed delivery plan with themes for action. And that we're hoping we'll be able to complete that by the end of the year. And in addition, there's been some discussions around research opportunities, and the Director of Public Health, Justin Barney, feels that we need to have an academic board in order for that area of work to be taken forward. So in terms of where we're at with that progress, Councillor Hamilton assessed it as being complete. In terms of recommendation 3, we have made progress on recommendation 3. We've got some early mover projects that we're undertaking. The first of those is around our population health management work, and that pilot project has been agreed by the integrated care system, and that will provide data and insight and evidence of achievements going forward in terms of how we're progressing. And there's a partnership of organisations that are involved around supporting health and pregnancy and the first years of the baby's life. And that project aims to link and integrate local data on health, demographics, socioeconomic determinants, all focused on the whole infant mortality agenda. And what we're hoping from that is those insights will be able to include visualizations and models that will help inform the design and implementation of a much more responsive anticipatory pregnancy and newborn care approach. There's a data scientist who's been taken on to undertake some of that work, and we're hoping that they'll be in place by mid-November. There will be an updated paper to the Health and Wellbeing Board on the PHN work stream, and I think that's already been, you maybe already received that, but that's what Diane conveyed to me. And that there's a further paper being developed that's going to be presented to the Birmingham City Council leadership team, and I don't know the date of that because that's my colleague who's involved in that piece of work. But Dr. Diana Arkin Terran will happily update you and give you that information. Another piece of work is on our work with schools, and this is focused on co-producing aspects around relationships, sex and health education around cousin marriage, and that's been very positive. Some of the work
was held last Friday, and I'm happy to give kind of we're trying to develop. The school has now got a package of materials to support teaching of genetics in their classes, and it was the kids did a pre and post questionnaire and significant improvements in their understanding of that topic ensued as a result of that piece of work. So I'm happy to report to you. I haven't done the analysis yet because it only took place on Friday, but I'm happy to give you that further information on the improvement in our understanding in that first workshop. So the other piece of work, one of the other pieces of work is around hearing from ourselves and her communities. And we had some focus group conversations about pregnancy that with refugees and asylum seekers, people with sensory impairments, people of the working age with long-term conditions, mental health conditions, teenagers, university students, care leavers, pregnant mothers and with their husbands, and South Asian women. And all those reports have now been received and being compiled, and we've got a first draft back that we need to check back with all those that have been engaged with it. So what we're hoping to utilise some of that report for is some further work on cultural competency as well. And as the themes that have come out from those discussions and conversations around cultural competence, education, awareness raising, how to promote services more appropriately, things to do with preparing for pregnancy, how to stay well and healthy during pregnancy, contraception, things to do with health literacy, language and interpreters, having a voice, being able to answer a question around, are you intending to get pregnant in the following year? So which is known as the Just One question, and how they want to be asked that, and things to do with mental health and well-being. So we've got a training program for community researchers that's underway at the moment with South Asian community, Black African community, Polish, Eastern European and Chinese communities. And nearly all of that is being complete. There's just one group that won't complete their training until December because they took a break over the summer, because many of the women who are involved in that have got children at school age, and so they requested to have that time off. So that will be finished in December. Then there's a piece of work that I've been working with the Birmingham Maternity Partnership, known as the Bump Board, and they're very concerned about cultural competence and cultural compassion. Some of the pregnant women's stories about how their interactions with our services have highlighted some things that we feel that we need to consider, and they've now committed to undertaking some senior level discussions during this month, in October being Black History Month. There's work on immediate postnatal contraception, and that's being very positive and seen as a very good piece of work nationally as well. And we're hoping that we'll be able to just take this forward with the integrated care system and look at how this might be funded going forward. We've just in the process of awarding a contract for a piece of work that looks at the economic cost of genetic conditions using a kind of desk-based cost-benefit analysis, looking at all the different genetic autosomal recessive conditions, and hopefully that will then enable us to kind of make some suggestions about how we may take some of that work forward once that piece of work is completed. It should be
they foresee it taking about 6 months, so we would be looking to complete that next year. So in terms of the recommendation, was around the work of Professor Solway and the 4-strand approach. That will definitely be incorporated within the infant mortality delivery plan, and so that there's no question about it. So we have ensured that will be undertaken. So, and then we've got the date set for next. So we were asked to make sure that we came back and spoke to you before the 31st of October, and here I am with you. So I think we can safely say that that's been achieved. So thank you very much for all of that. So I'm happy to take any of your questions.
Okay, Councillor Cock.
Yes, thanks, Chair. Thanks, Darren, for your contribution. It's great to see the amount of effort and energy that's been thrown into this in response to our inquiry, so I want to acknowledge that. I'll be very brief here. On recommendation 01, and there's a couple of outstanding questions here. The terms of reference we don't yet know. They're in development, it says here.
Yes.
Do we know when we will see?
I'm meeting with the independent chair this week. So after I've spoken with her, we can set the timeline that, and then I can give you more of a proper position.
Thanks. I think that RO1, we would need to see the terms of reference and also to see which representatives have actually agreed to take part in the task force. So I think my recommendation, Chair, would be that we call this a 3 in progress rather than a 2 completed. It's an outstanding item that's still in progress with. 1 is the terms of reference and final completion. So recommendation, Chair, would be that we must be 3 and not 2. And just finally, on the targets, you've obviously modified a very ambitious target, and I think Tilson will bear me out here. We've decided we will press a very demanding stretch target in our reports, recognising that that might not be totally achievable. So I see the scale was back a bit. Can I just be clear, though, that the percentage reductions continue to be reductions from the 2015?
Yes, indeed. That's what's going to be within the health and wellbeing strategy that Justin will be taking to health and wellbeing board.
Okay, so I guess, and finally, Chair, when we do get the delivery plan, we can make our own view about whether it's reasonable, given the delivery plan and resources, that those targets could be achieved. I think that's something we can come back to when we next meet.
When we next meet, yeah.
Okay,
Thank you. That Councillor Clancy.
Oh yeah, just very quick one. Thank you, Dr. Stevens. You just briefly went over the training of community researchers, and you said 3 out of 4 completed theirs, and the issue with the other 4. Yeah. And obviously, consanguinity was a big aspect of the report and research that we looked at. So I'm interested in when this says training of community researchers. I'm more interested in when are they getting out there to work with the communities. So we've got to give these teachings of these potential pitfalls. Yeah, so we've got 3 groups that are complete, and it's the one with our Asian community that is one of the things about that particular group is she's the person who's doing their training is very, very rigorous. It's somebody from the University of Birmingham. I have been in discussion with her because one of the things that we really started to look at is around what methodological approach will we take. And what we're thinking is that we might end up deciding to use a more participatory action research approach, so that we get women being able to go out into the community and feedback, and then we can look at what happens next. So it's going to be a bit more of an ongoing process. So more fluid. Yes, absolutely. So that we look at how things are going, test things out, review and have further discussions and make considerations about, well, what needs to happen next. So it's rather than a kind of training that is from A to B,
ends and then we go send everybody out. What we want to have is a kind of process by which we continue to support those women and train them if they find there are other things that they need to have their confidence and support going forward. So that's the approach that we're taking, which will be a bit longer term, but I think more effective as a result.
Thank you, Chair. While we're talking about the different communities, the events in Afghanistan over the last few months have caused a lot of families fleeing Afghanistan and coming to Birmingham. And you will have influx of them in the next 6 to 12 months. Are there any plans how to engage with those families?
So in the workshop we held, we talked quite a bit around homelessness and making sure that we have support for vulnerable women. So I imagine that we'll end up with a subgroup that will focus on some of those aspects. Because one of the things that's come out from the discussions we had around an action plan, they said, let's not have a strategy. What we want is a development plan, action focused. Because then we can get a momentum and have those things to do with that are kind of coming to the fore and being able to develop plans around what we do to address them. And so that whole action research approach, I think, will be pretty helpful in addressing some of those issues as they arise.
Thank you, Chair. Thank you, Marion. It's quite an interesting read. I tend to highlight things as well. Certainly would agree with Councillor Pocock that R1 should really be a 3. I was certainly enjoying that. With that, and I'm grateful for Councillor Clancy for bringing up points in R03. That was my particular interest as well, with the community researchers and particularly with the community and faith leaders. And it's quite interesting because this will be of great interest not only to myself but also to Councillor John Cotton, who is the portfolio holder, and me being the shadow, and we do work very closely together, I'm pleased to say, on social inclusion, community safety, and certainly with equalities. And both myself and John are on the Without Inequalities board, so we'll be sort of monitoring this and taking this forward, Chair. Excellent. Thank you.
Thank you. You guys got questions? Okay, can I ask one? In terms of training for the community researchers, how much is their methodology going to be impacted by the effects of the pandemic in terms of contacting people?
That's one of the reasons why this participatory action research approach is so that we can check in on a regular basis, because we are aware that we're likely to see further outbreaks continuing. We're not going to say goodbye to the pandemic. It's with us for a while. But so what we are intending to do is ensure that we see what's feasible and what's possible. The use of WhatsApp has been very helpful. Some of the training that we've been doing has been through using Teams, and so I've been able to join some of the presentations that the researchers undertaken. So we will continue to review that. And I know that everyone would like to see us getting back to being able to do things in a fashion more like this, and we will look for venues where there's enough space for social distancing and all of those things to take place. And so I totally take on board your concerns, and I really seek to address that we do use as many ways and means as we can to make sure that process is undertaken in a fashion that's going to work very.
Okay, just make one comment in my non-technical job. We do work with a variety of ethnic groups, and sometimes there's been a reluctance to use the Teams format because they find it culturally and technically something they're unused to actually working with. So I wonder if that's been an issue for you so far.
There's been
as we become, I kind of came out of having to use Teams the whole time, we've been trying to use, so some of the work has been undertaken with the women researchers, community researchers in person, those, but the follow-up sessions have sometimes been through using Teams or WhatsApp. So we're trying to kind of make sure we have a blended approach, and so to buddy up people who are less technologically savvy with those that are, and hopefully get through it in that manner. But I totally understand your concerns.
Chair, with your outside work, you mentioned that. Do we know the particular reasons why they feel uncomfortable? Is it actually about being in person because they can turn the camera off, or is it down to the situations, please?
I think sometimes it's an unfamiliar concept for many people. I think if you work in certain settings using Teams or Zoom, it's something people become familiar with over a period of time. And if you're not used to using it, if you're doing it at home by yourself, it can be a bit of what do I do next? But I generally don't know. So I think it's trying to upskill people, but also using a format that people feel happy with.
Yes, I'm actually going to be attending some training on using technology because one of the things that I've noticed is that some Zoom sessions or Teams, whatever, are not very interactive. There's one person who does all the talking, and then you might get a few people interjecting, but it's not really a whole discussion like we've had here. And so I'm really interested in seeing and learning how to use our different platforms in a more interactive fashion. So, yeah.
So you can't get body language on easily on Teams. In terms of trying to bring people into conversation.
I think from both sides, it's that interesting learning and understanding and helping, and that people actually get used to it. I mean, some people may never want to do it, but it helps to have training it so they become comfortable and at ease. That obviously how it's helping them are great. And finally, I was listening to LBC when I was coming in this morning, and sadly, maybe our guest behind us might know a little bit more. There's a little bit of concern about COVID starting to rise a little bit. We was talking about the masks and other things might be coming back. That's as much as I heard, so I hope it isn't. That's just a concern and not a reality, but probably we'll find out later on today.
Thank you for the presentation, that was useful. I think we now need to go through the items one at a time to make individual recommendations and see if we agree with cabinet members' assessments. So I think for recommendation one, the cabinet member got a level 2. It was a recommendation of level 4, 3.
That's progress made in the future.
We have to go with 3. 3. Okay. And then recommendation 2, we've got a cabinet member assessment of 2 again.
2 and 3, isn't it?
2 is accurate, because it takes a decision on the target, whether or not it will not really applies to the second part of that, so which is really possible.
The rest of it, I understand is all correct, but it's just that one, the first one that you felt being a bit too optimistic.
Okay, so we're happy to go for the recommendation of 3. Okay. Then R03, we've got recommendations for 6.
That's still in progress.
Yeah.
Thank you.
Okay, that's it. 31. And then 4, we've got a further recommendation of 6.
Great.
Agree? Okay. And then 5, we've got a recommendation of 1.
Because I'm here.
Well, yes. Yes. Agree. Your presence is noticed.
Happy Dr. Thank you very much for the presentation. It's been really useful.
Thank you. No, and I tell you, the piece of work is really fascinating. I could tell you so many things about it, and next time, hopefully, I'll share a bit more.
You can tell me on the Teams. Thanks, Mary.
think the next report would have been due up to government in 6 months' time.
Yes, that's fine.
Just before the election, so I think maybe we'll be looking to be for the next year, which will probably be July.
Okay, that's fine. I will let my team know so that they'll think. And that would mean we have a bit more of an interesting, I'm sure we'll get a bit further on as well.
I'm sure you will do. Thank you for today.
Yeah.
Patients wait a little bit. Could I ask you please to introduce yourself before you start the presentation?
Gemma Rower, I'm the Deputy Director of Communications Engagement for the University of Birmingham as part of the vaccination programme.
I'm Katie Gilmore, I'm Senior Programme Manager working for UHB on the COVID vaccination programme, including this one.
Okay, I'm Lisa Maxfield, I'm Associate Director of Part Care at ESOL CCG, and I'm the lead for COVID vaccines and CCG. These are my colleagues, Dr. White and Dr. Sabina Solomon, who joined us for the access.
Shall to take it away?
We have to.
I'm sure you've all had a chance to have a look at the slides before today, so I won't go through all of the numbers in detail, but for COVID, we've been working through the JCVI cohorts, which started in December last year, and we opened the last cohort on there in August. The 12 to 15 program started since in September. We have an average uptake in Birmingham of around 79% first doses, and just shy of that for seconds. Not on here, but the booster uptake, we're at around, I think last week was around 40-45% across the system. We know that our figures are lower than the national targets and the national average. However, the numbers are much greater than what we would normally see in a vaccination programme through Birmingham. There's been a great deal of work done to work with some of the lower uptake areas, and I think we just through the data that we get, which is all collated nationally. The slide. The next slide is the ethnicity uptake. So we can look at uptake by ethnic group, which allows us to focus and work with communities that we know we haven't seen uptake, as well as some of the others. The main ethnic groups have been the Black ethnic groups that we've worked with. We've had some lower uptake with Chinese, but we've worked on a lot of work throughout the bands, which improved the uptake there. Although the booster program has officially started now, we are still seeing what is being termed nationally as an evergreen offer, which is first and second doses that continue alongside the booster program. We are still seeing numbers coming forward each week for first and second doses. Next slide. We can also look throughout through from a ward level point of view. None of this data, I think, is a surprise. We know from the health inequalities work that the system works through the areas that are more challenging than some of the others, and we have made sure that the van location, we've had mobile vans going out offering vaccinations within communities, and we've tried to find locations within those communities that are lower uptake, and we have actually seen through that and putting the vans in high footfall areas, that's improved the uptake considerably in some of those wards. We had a number of wards that were below 55%. Yes, sorry, just as I was checking, sorry, that were below 55%. Each week we see more and more come off that list, so that shows the work that's continuing. They're areas that we have worked with, we continue to work with. One of the other things that we've done for this is putting in vans in Grand Central. So we've had some real positive engagement with the local community, businesses within the community that have allowed us to put the van there. And that's when we analyse the data from the people coming forward to those locations, they are predominantly from the areas that are lower uptake.
Sorry.
Oh, it's all right. Yes, yeah. And I want to move on a couple of slides, if that's okay. Could we go to the located sites? So we obviously Birmingham Solihull STP is focusing on that part of Birmingham and Black Country and West Birmingham. STP is focusing on West Birmingham. But what we've tried to do is make sure that we've worked collaboratively, and so for Birmingham as a whole, so we don't differentiate as far as the public is concerned with what's on offer. So we have 27 primary care network sites across Birmingham, which includes one site in West Birmingham, which is a collaborative of the PCN groups that are based out of there. We have 40 community pharmacy sites for the winter programme, of which half of them are active at the moment. It's quite an extensive national programme to get the community pharmacies up and running. We are working hard and pushing to get more and more active each week. We have one remaining vaccination centre for Birmingham at the current time, which is at Edgbaston Cricket Ground. We have Millennium Point and Aston Villa Football Club early on in the programme, but they went back to doing their normal business. So we have pulled out of those, and we are looking at alternative locations to take us through the winter and into next year. We have 4 mobile vaccination vans that can offer either in a van or in a pop-up facility, as well as hospital hubs which are focusing on vaccinating health and social care workers. In addition to that, we have the community providers which are who are focusing on vaccinating our housebound and in the schools programme. For an update, as of Friday, there have been 61 school visits across Birmingham with over 7,000 children vaccinated through that programme. There is huge amounts of work going on at the moment to focus on how we mop up and how we support children who aren't in schools, so how we can vaccinate out of schools. That's been not in our gift up until now, but it is in our gift going forward, so we will work through that. I suppose just picking up a couple of the challenges that we've had, one has been flu supply for the winter. So the flu supply ordered in January is not enough for us to reach the targets required from the national team. There is a national flu supply, but it's still not clear what the process is around how we can order that, but we will be allocated based on fair shares from NHS, the regional team, that we just don't know the details of how we'll get that. And I think the other big challenge that we've had has been workforce. These are a lot of people that are being pulled, particularly now, into other health and social care areas of work that we're focusing on as well. However, there is commitment from all parties of the system to make sure that we can staff and resource and ensure that we have an effective winter programme for both flu and COVID. So Gemma's just going to run through some of the engagements that we've put in place throughout and going forward into the winter.
Thanks, Kim. So across all of the cohorts since December 2020, it seems like a very, very long time ago now, we've taken a targeted approach depending on which eligible group we were focusing on, really. And in between December and now, we've actually carried out an evaluation on how our comms and engagement has been going, what we should do more of, and what we should probably not do again, because it has been very effective. So we're quite, we've got quite a lot of information, data, insights, and knowledge at our disposal now in terms of what works well and what doesn't work well in terms of motivating people to come forward to have vaccination. So our current areas of focus are obviously the 12 to 15-year-olds in schools, 16 and 17-year-olds, the boosters, pregnant women, and care homes. So for each of those cohorts, we've taken a different creative angle and a different approach to make sure what we're doing and how we are executing our comms and engagement is really trying to hit the mark. So for the 12 to 15 and 16, 17-year-olds, we've used a theme of fear of missing out, or FOMO, essentially focusing on, the things that young people won't be able to do if they come into contact with someone who's got COVID, they catch COVID, missing out on the exciting things they like to do, like playing football, netball, and for the older young people, the 16 and 17-year-olds, meeting up with friends, going to parties, that type of thing. For the pregnant women, our focus has been very much on facts. There's some very stark facts and data and information out there around the number of pregnant women who are getting seriously ill from contracting COVID. For example, I think it's 1 in 5 women have to have an emergency cesarean. There's a lot of women on, quite advanced ventilation, etc. So all of our comms and engagement around that has been trying to make women aware of the facts in order to help them make the right decision for them. The care homes work, myself and my team have been involved with supporting both local authorities with communicating, engaging with care home staff, and that's been going quite well. We've produced a range of assets that focus on the law changing on the 11th of November and the requirement to have both vaccinations to be able to enter a care home. That's also translated into the NHS and to professionals who go into care homes such as GPs and other NHS staff, because obviously they need to be vaccinated too. We've done a suite of materials, and that's overseen by Graham Betts on a Wednesday morning, and I attend that programme board. The figures for care home staff are looking fairly positive now from what I understand, which is great to see, a much better position than it was a few weeks ago. And also just to say, we are focusing on the sort of seasonal elements that we've got coming up in the calendar. So in terms of the sort of catch-all campaign for any dose, first, second booster, we are doing a current campaign focusing on Halloween and Bonfire Night, which is quite light-hearted and quite engaging, just trying to make people aware. And there will be a Christmas and festive period campaign as well as we get into November, December. And all of the things I've described are used across a variety of media, physical assets, also online. We also work very heavily with the Council's Public Health Comms and Engagement team. I've done a lot of engagement with protected groups, faith groups, and other people who've been a bit more challenging to reach and persuade. So that work is actually going on and has been going on for, since December 2020. We work very closely together. And we also, wherever possible, take a very hard line with anti-vaxxers. Unfortunately, there's been a lot of activity recently. A lot of social media content particularly is being hijacked by anti-vaxxers. And we've had to take, some quite strong action in terms of reporting some of it to the police. And also clearly blocking people and deleting comments where appropriate, because some of it's quite concerning. So that's just a snapshot really of the work we've been doing. I hope it gives you a general idea. If anyone would like to see the assets and the materials that we've got, or would like any more detail on the evaluation piece that I described, then I'm very happy to share that after the meeting. Thank you.
Thanks, I'll be very brief because of time. At the start, you presented 2 tables, one showing the older you are, the more likely you are to get the vaccine, the younger you are, the less likely you are. But also the ethnicity table, you've obviously shown there is an ethnicity profile too. Taken separately, these are misleading because there is an ethnic dimension to age structure in the city. The older people are, the wiser they are, the younger they are, the more diverse they are. So I think what would be really helpful if you can do is a table, so an age-adjusted ethnic profile, because some of the figures here show certain communities, if you like, lagging behind, will be associated with the fact they're younger. So what we could really do with is having those tabulated. If we could do it really good question. And just last comment, social media, anti-vaxxers, well done, more power to your elbow, and great to see the progress.
Okay, thank you. First question on terms of the ethnicity one, looking at the figure for travellers, which was significantly lower than a lot of the others. Is that a similar picture across the country?
Yes.
I'm assuming it would be.
Yeah.
And I'm assuming the following question that would be, what action is being taken to try to raise that figure both locally across the Midlands and potentially nationally as well?
Well, I know there's been a lot of work that's gone on to try and identify travellers and travelling migrants. I know there have been vans that have visited travelling communities, and again, doing the work through the Justin Varney's constant engagement team. That is an ongoing focus for us in terms of any additional activity or anything else we can do to encourage travellers to come forward, or alternatively take out the vans or the model to those particular communities, whichever would work best. But I know there has been efforts, such as with the vans. I think there have been some speed bumps, shall we say, in locating travelling communities, and I think it's been a bit of a mixed picture really in terms of the success of that, but more needs to be done, you're absolutely right.
I think there's been some challenges around once we've got to the site, the travellers have moved on. And I think this is a picture definitely seen across the Midlands, I think probably nationally as well.
It's just interesting in terms of what was being done nationally, because I'm sure a lot of from the people I know in that community, which isn't a huge number, they do travel around. So I just wondered in terms of is there sort of a national or a regional picture being built up in terms of the best place to link into these particular groups?
I know there is a regional one, and I know there's been some discussions from other systems that have experienced similar problems to what we have. And I think I think the key is to get in with the right individual within that community, and if we can link in with that individual, then more within the community will come forwards. But that's probably been our biggest barrier.
Thank you. Interesting.
Thank you, Chair. My question is around people working in care sector and care homes. A tiny minority are still resisting having jabs. While they should be at the forefront of promoting these vaccinations and the impact, positive impact it is having in combating COVID. So what are the main apprehensions not having jabs, and how are they being dealt with?
So we're not really the lead organisation for care homes, so that would need to be directed to Graham Betts and his team. I've only got the update I gave because I actually go to the meeting on Wednesday. There's an awful lot that's been done. I know your colleagues at the council are having weekly telephone calls with care home managers, and as I said, we've done an awful lot in terms of constant engagement support to make people aware that it's a legal requirement, the benefits of having a vaccination. But really, I probably can't give you any more information than that. Really, because Graham and his team are the lead people to that.
As far as the anti-vaxxers are concerned, which really do concern me, they are very active, particularly with the Afro-Caribbean community, I know. What are you doing as far as monitoring social media is concerned to try and combat it? Because this is where it's all happening. It all started off with Blackberries, but we've now graduated to smartphones and 5G. So the monitoring needs to be very extensive, because if you're not nipping it in the bud, they've got an enormous lead on you.
Well, there are a number of things really. So a lot of the anti-vaxxers communicate via WhatsApp in closed groups. So essentially, it's a bit of an echo chamber for them. So that's one thing. When we put content out, and I say we, the ICS comms group, so all of the health and social care organisations across the patch, put content out. We've each got comms teams who actively monitor social media. So on a daily basis, comments will be deleted, they'll be reported to whichever channel, so Facebook, Twitter, Instagram, and we have had unfortunate occasions whereby we've had to report malicious communication to the police because it's been quite frankly disgusting and personal and horrible. So there have been some unfortunate occasions that that's happened. We were made aware of an anti-vax protest outside Lloyd House, which was suggesting that a boy from Solihull, he was 17, who died in September, his death was as a result of vaccination, which was untrue. So we did an awful lot to clarify the fact with the media and on social media that that wasn't the case with the parents' consent. Very, very sad case indeed. Nevertheless, despite us reporting this video to YouTube and all of the content, the relevant channels, Facebook, etc., it did take some considerable time for them to take that down, and that's what we're facing. You know, even though we quote the guidance back at YouTube to say, you know, this contravenes your guidance, it does still take them an awfully long time to take this inaccurate, you know, and quite upsetting content down. So it is literally a full-time job, and as comms professionals, we're all on the same page with it, and we do our very best to try and remove any inappropriate content.
Okay, you mentioned the police. Are the police also monitoring social media?
You know, if I'm being really honest, the occasions that we reported it to the police, it hasn't been very successful. They're not necessarily that interested. I don't.
Okay, I take that because I'm on the local engagement COVID board as well, and I've mentioned this to the police. And they assure me that they are monitoring the social media. Now you're saying that there seems to be a bit of a mismatch between.
I think operationally, when I as an individual report an incident of malicious communication to the police, so the 17-year-old example I just gave, which was quite, you know, quite bad. The reason they did is because it's not directed to me personally, and it's directed towards an organisation, they struggle to find the right way to deal with it. So if they said to me, Gemma, you've murdered this boy, then fairly, you know, fair enough, that might be, you know, a different situation. But when they're saying the NHS has murdered this boy, or, you know, UHB have done this, it's more difficult for the police to take action. I've had to do it twice, and that's fairly consistent response back from them. We do have very close working relationships with the police comms team. You know, perhaps I need to be back that way as well to put more on their radar.
Yeah, I think that would be helpful. Yeah.
Yeah.
Any other questions?
Yes, Chair, thank you. Just a couple of questions, if I may. Mentioned about the 40 community pharmacies and the 6 hubs. I just wondered if we have a time frame at all when those are going to be online. Because obviously, I think that there's 20 still pharmacies still to come online and 3 hospitals, and akin to that is any other communication things like leaflets or whatever that's been possible to do. So pleased to hear about the community providers helping with the housebound. That's good news as well. And I'd be interested to see how it's going with the 12 to 15-year-olds, how that is progressing. The one that I've got is, I noticed it said 130, I think it was 130,000, I think it was, short doses. So I've lost it now where I saw it. Yeah, 130,000 doses, this thinking that will be short. And yes, and finally with the anti-vaxxers, listening to Councillor Tilsley as well, that one would hope that, as mentioned earlier, with the community and faith leaders, that is also helping fighting against, as I know they are, working against these anti-vaxxers and the terrible comments that they make. Thank you.
I will try and remember all of those as I go through. So with the community pharmacists, the initial deadline set by the NHS England national team that are in charge of this was the end of September. We are beyond that. I am pushing. I hope to have a meeting with them this week to be able to identify the ones that are yet to complete the onboarding process, as they term it. So I would hope to have something in place very, very soon. With the hospital hubs, we've staggered the openings of those to meet the 6 months post the second doses, so when they were open for the second doses. So the last couple are due to come online over the next 2 weeks.
Okay.
The flu supply, the I don't know the exact numbers that are going to be allocated to us as a system. The regional team, but there's a national allocation. I think there's yet conversations to be had as to how that could be split regionally, and then we will obviously get outlet shares of whatever the Midlands region gets. We're still waiting on more update on that and detail around what the process will be for sites to request additional vaccine.
Yeah, the other two was just about the websites and things that not everybody's on websites, and what of the communication has been thought of, and then just finally how it's going with the 12 to 15-year-olds at school. Because I know there was concerns with parents, etc. I was curious.
Yeah, so in terms of the communication, throughout the programme, we've deployed a range of things, both online and physical resources. So just to give you an example, so with our Christmas festive period campaign that's going to be coming up, we'll be all over buses, all over trains, ad shells around the patch, as well as, you know, media, social media. You know, we really are exploring all options in terms of getting the word out there, really. So I'm hoping that you'll all see that quite soon.
Yeah, that's good one, thank you.
And in terms of 12 to 15 uptake, we're seeing around 30% uptake at the moment. Some schools are more, some schools are less. As an average, across the work we've done to date, we expect it to improve. The very early days, I think there was more concern. Parents wanted to see what was happening. We've got quite a detailed programme of work post half term, so this week and post half term. And then to supplement all of that, there will be the option for children who haven't been able to be vaccinated in school because their consent forms were returned too late, or they were absent on that day, or they just changed their mind. And for those children who aren't in school, to be able to get vaccinated elsewhere. And we will work, the comms team will work to help make sure we get all of that information out to everyone.
And actually engaging with head teachers. I've been involved in a couple of Teams calls where we have loads of head teachers on, and they've been inputting into, you know, what we can do, working with us, which has been really, really great. So there'll be more of that too.
Thank you for those who get answers, and thank you, Chair.
Thank you. Can I just make one point in terms of what I would say, with the big potential shortage of the flu vaccine, could you keep the committee updated as to when you receive information regarding that?
Thank you, Chair.
And then lastly, for me, from a personal point of view, I had my booster vaccination in Grand Central on Sunday, and the anti-vaxxers appear to be all lying down in front of the capital house for some reason, I'm not sure. But the point I wanted to make was, I think the last time they were in the Grand Central area, some of the anti-vaxxers were some of the actual volunteers, and I want to express my appreciation and expect the committee as well in terms of the work that some of those volunteers actually do, because you shouldn't have to be spoken to, I suspect, in the disrespectful way that some of them were spoken to.
Well, I'm due this afternoon, so I might be making some suitable comments.
Next week,
One of which might be off. Push off, yes.
Okay, thank you. Unless anyone else has got any questions, thank you very much. I appreciate it.
Just check we're going to get that table, okay?
Yeah, I will have a conversation with our informatics team to see if they can pull that data. As I said, it's national data, so we're limited, but if they can pull it, I will get it.
Yeah, we had this problem before.
Okay, primary care.
First of all, apologies for Paul Sherry, who's calling today. He's not able to be here, so send his apologies. So, shall I let my colleagues introduce themselves? I'm Lisa Maxwell, Associate Director from, and I'll start with,
I'm a GP working in Birmingham. I'm also a director of the PCM.
I'm Dr. Mike Baker. I'm actually from Solihull, but I'm not that's as my advisor. I work in Solihull, but I am the primary care clinically primary care coordinator. So I assist CCG with some clinical advice for the ESOL CCG.
So, Chair, if it's okay with you, I'm not really going to go into any detail around the slides that we've kind of got, but I'm happy to take any questions on there. I suppose the access issues is a fast-paced thing that is changing all the time. I suppose the key things that we want to point out, we have been to the host on a number of occasions, and recently went to the joint cost, where we reviewed the activity and the workforce pressures in relation to all the concerns that have been raised. As I said, it's not our intention to go through the pack that you've received, but however, just to really just point out that general practice is still open, it hasn't closed, the pandemic continues, as we've already had that conversation this morning, and I've heard others comment on that while they've been sitting here as well, and Marian's doing her piece. I particularly want to just say that the operating model as it stands on slide 45 is the way general practice is currently operating, and will continue to operate in that way. I do want to say that general practice, the morale in general practice is exceptionally low. You can see my colleagues, Dr. Summer here nodding her head. We're losing people, and I'm sure Dr. Baker and Dr. Summer will start to give you some very live examples of that. And we want to do our very best, really, to try and support our staff and support our patients most of all, and give the most safe working environment for staff within primary care. I suppose the key things that we want to come across today really is that like some of the concerns that raised on the joint costs, that our communications haven't always been as best as they can be, and this is always a challenge because we've got national communications and local communications, so we need to marry these elements together. Some of the conversation that we talked about the joint costs was around telephony. I suppose that when I said that things have changed, you will have known that on Thursday at midnight, a national NHS paper was published called Our Access, Supporting General Practice, and that obviously now changes slightly the position in which we're in the CCG and the way that we're going to be working about general practices. But in that document, it clearly states about using cloud-based technology. I'd just like to assure the committee that we have of our 160 practices across, but it's learning inside of. We have 145 practices who are already on a cloud-based system. We actually only have 15 practices to move into that. So nationally, this is what and the government is asking general practice to do. We're all already ahead of the game on that. So I just want to give the committee assurance on that. I suppose, as I said, the pandemic is far from over. We've all just had some concerns about people not taking boosters. The levels going to go up. We have to keep general practice safe, and I think one of the key issues that we do have in general practice is estate, and putting poorly patients in waiting rooms with other patients, and that's why we're offering the telephone triage model now. And screening patients before they come in. And this may not be what patients want, but actually it's in their best interest in keeping them safe. But I'm going to let someone comment on that in a moment. And I suppose what we do want to say is that there's such a huge amount of rushing now in general practice, and it's really a major impact on general practice. That we want to support that. And part of this winter access monies will be supporting general practice and doing some training and support in relation to that. Someone come in, that's okay. Just to comment on general practice and is that okay?
I'm happy. If you want to.
So I thought I think I'll probably speak from a very practical point of view. So as my time as being a GP, I've never known it so busy and crazy. So people, they can start from 7:30, I'll get home till 9, and it continues. And the issue is demand. We looked at our telephone data, we've had an increase of about 30 to 40% increase, and we've lost staff, we've lost reception staff because they couldn't cope with the pressure. And so recruiting more reception staff and training, that takes time. We've lost doctors, and we've lost a partner who's burnt out and now has reduced his sessions. We've got one doctor who's doing abroad. And we kind of understand why we're having an increase in demand. A lot of it is because increased environmental illnesses, also delays in hospital, outpatient appointments is having an impact on our workload. Also, patients who may be held back and not contacted us about 18 months ago and now contacting us. So we are struggling on a day-to-day basis trying to cope with the increased demand. And the current way of working is probably not sustainable, I think. Probably agree as well. So we're all pulled back, and we've got our HCAs come off from their clinics to help us with the telephone calls. We've tried it online as well, but it just seems to be never ending, and it's pretty hard. And at the same time, when Kim was talking about the vaccination program, we're offering a daily walking clinic because we work in a highly deprived area with low uptake, and so to increase our uptake, we kind of decided to have a daily walking clinic. But that doing that work as well as trying to provide better care for our patients. So it's difficult.
And just to follow on from that, I think doing so in the pandemic, I think that's the significant issue here. Cases are rising. They're not much dissimilar than they were last year. And what we have is a unique challenge. Primary care 2-3 years ago was already on a breaking point. We talked about primary care access, I think, several guys over the last 5 years to a decade. It's not a new thing. But what happens is with the pandemic, it does create a peculiar set of circumstances. I think one of the things is every single GP I know wants to see everyone face to face. He absolutely loves patient interaction. That's what I came in to do. But what we have is a set of circumstances where we simply cannot, when we have a waiting room that's about an eighth of its size, put 20 people in there, some of which have illnesses. We do not know it unless we actually phone them first and actually see what's going on. There's an awful lot of patients do come in actually or hide their symptoms. They're anxious to this. So it's really hard, I think, at the moment. I'd echo the strain on all our staff. It's not just the GPs, it's our whole workforce that are finding it knackering, usually long days. We've had several instances where I work of aggression towards staff as well. And so we're into that cycle. How do we break this cycle? Which I think is really interesting. We've got our new access fund that could help. But what we really need to be understanding is what is the activity? How are primary care actually working? The data has always been the last few years we've been trying to understand data. It's coming now. We've there's a new set of data that will be available. It's not quite ready yet. It's being extracted at the moment. We started to be extracted over the last month or two from all primary care to know, how are they performing, what type of points are they giving. But data being data, it takes a while to really understand it. And that's, I guess, one of my roles as well, as when we start to really understand how to understand it in medical practices as well. So we have to keep to a phone-first model to an extent, but it's not saying that patients won't be seen. I think an awful lot of primary care is actually seeing patients face-to-face. Some patients don't want to be seen face-to-face as well. Lots of people who still want to stay and talk to us either via video or phone, and we're trying to encourage them back in the room. We're also been working hard, especially over the summer months, since the last what the SOP that comes out from NHSE. It's been really trying to identify those in the disadvantaged communities and also people with serious mental illness and disability and the like, trying to get them in, trying to get them reviewed and see what their needs are, because that's a gap. It acknowledges the gap. We're really trying to fill that gap. Just to give you a flavour. Yes.
So I suppose just to sum up, really, if that's okay now, we are committed to continue to work with general practice and support them through this really difficult time. We've communicated the new paper out to our practices and said that we'll continue to work with them. We want to continue to support the operating model that currently in place. And we've, as you well know, in the information we've given you previously, developed all this surge capacity or incentive across Birmingham to try and support information through patients through that. And we're working with our local medical committees to support, so that everyone wants to support general practice. I suppose the key issue will be that we have to submit a plan to NHS England within 14 days, so it's 28th of October there has to be a plan to go in how we access that winter money, how are we going to work with our practices, and you will know from that report and the media that surrounded it was highlighting performance issues with percentage of practices that are not got face to face. And it's understanding the data that sits under that and understanding the working with our practices about that. We will be continuing to support general practice very closely.
Thank you for the big presentation. Really appreciate it, especially GP's comments. Questions from members, Councillor Pocock and then Councillor Telsley.
Thanks, Chair. First of all, I think it's scandalous that the tax has been laid on GPs in the media, social media. I think it's totally unfair for the general practice to have been targeted in this way by people, obviously angry, distressed, whatever else. So I think we want to give our support to all of those in primary care who are struggling to cope with the new environment. Where do we go from here? I think there is an issue to be resolved about the future of primary care, which we haven't bottomed out with the British public. I think the GPs made the point. The existing model was creaking at the seams very best before the pandemic. There has to be a different way in which to deliver primary care. What's missing is a recognition in the public that there is going to be a shift away from, I'm feeling ill, I'm going to go and see my doctor at surgery, to, I need support from primary care. I will get that support from a range of possible channels. And let's think about the way people would choose the channel they prefer. Some people might want to queue up a lot of other very ill people in the surgery and wait to be seen by a doctor. I think a lot of other people would rather see the service as a virtual one, as a telephone one. It's more convenient. You can be at home, get on the phone, have a chat, and keep away from other people who are ill. If we move to a more positive model, that you've got a choice of channels, and that the general practice is moving, let's call it primary care, to a model in which you've got a range of choices, which is face to face, but there are other channels available too. As I understand it, we've shifted towards primary care networks in order to allow you to see not your GP, but another GP maybe in the network who is a specialist in your condition, and may not see a GP at all. It might be another health professional. It's a totally different model, but the general public don't see that. My biggest worry, this winter access stuff, is kind of going backwards. Let's just all go back to queuing up in the doctors again. It's actually pointing us in the wrong direction. If the consensus professionally is that we need to shift away from the queue in the surgery model and into a more diverse range of services. So I think what the concluding comment is, I think we do have a job to do, and we as a scrutiny committee can play a part in this, to work with the primary care sector to establish a consensus around that better model and to communicate to our own constituents how that model is intended to work, including if you want to go and queue and see a GP or go on an appointment and go face to face, why not? And Councillor Brown made a very fair point, body language and all the rest can be very helpful in that interaction. You know that better than me. In other cases, it's an established relationship, you just need a chat on the phone. If we can get that model built, let's take Birmingham as a kind of pioneer city who can do this across a great diverse communities in Birmingham, we'd do a great job. So I think there's a job in hand for this committee to work with you over a period of years to evolve the service in a way that the public not just recognise, but actually welcome as a better way forward than the traditional model. But there's a big job to do, and I think we should plan our own work with you to try and build this up over the coming years. Thanks, Jim.
Could you just add a comment in before you answer Councillor Pocock? I just wonder how much this is a psychological issue at play here. There's a lot of perception now that a lot of society's gone back to operating normally. So I should be able to come in and see you normally. And if I can't do that, it's not because of the pandemic issue. It's just because of GPs, you're being difficult. You don't want to see me. Yeah, and I think we need, as Councillor Pocock said, that we do need to come up with a model that we can sell to people which actually encompasses the fact that the pandemic is not finished. And it's a question of looking at a range of choices. In very much effect, you don't necessarily need to go to the bank. Right? My wife used mobile banking. I prefer to use it physically, but we both accept as options. And we neither of us assume that the bank's been difficult.
I'm just coming in that I think engagement is vital. Yeah. I think it's something we've never done particularly well, partly as the NHS in general, partly because we're often constantly having to only access our work this week, 2 weeks. We've got to create a plan, and that you can't do. But what we can do, we need to have that engagement, that dialogue, which I think is vital, to create that. And as you say, it's not for want of actually, I think that GPs would like to see. And actually, you get a lot more information. You were talking earlier on when you're about teams and whether body language and the like. But at the same time, it's just simply not possible to do what we used to be doing, especially at the moment, to transfer that information to people.
Thank you.
Thank you very much, Councillor Pocock. I'm absolutely delighted to hear that Councillor Pocock would be really, really happy to work with you collaboratively on your piece of work. Absolutely. Thank you.
Councillor Tilsley.
In a previous incarnation, when I was a non-exec on the PCT, I ended up doing the allocations of GPs to patients, and the rule of thumb was about 1,750 patients per GP. The last figures I saw were considerably more than that. And yet, this is 10 or 12 years ago when that was considered to be a workable model. And I think we've lost that model now. And of course, there seems to be the thought that we can turn a tap on and GPs come out the end of it, regardless of the fact that it's probably going to take 6 years training from start to getting them in the field. So I think there's a perception that needs to be overcome. The other issue is that, okay, I believe in Dr. Finlay, because Dr. Finlay knew me, and he knew my background, and he knew my family. And I wonder how much of your time as GPs, if you are seeing a patient, and it's very rare that you see the same GP, unfortunately. So you're having to go over a certain amount of history, and how much of your time is going over the history in the background instead of dealing with somebody that you saw 3 months ago and you know their background. It's just a thought.
I would certainly agree. I mean, I'm possibly one of the older GPs, I might not look it. But,
we are bare as far as I'm concerned.
Who certainly used to have much more family practice kind of model, where I used to work for 15 years before things started to move and change. Talk about everyone who listened, what address they were at, and you visited them, you knew them, and I still kind of developed in that role, but it's just the modern world. It's so different now. As you say, the amount of GPs now per capita is reducing. In Birmingham, actually, we've got a very good story to tell about how we are retaining staff. It's a very good workforce and retention program going on, which is bucking the trend nationally. We're trying to make it a desirable place to live, and also to work, but also other issues like engagement, local staff and the like. But yeah, aspiring to that continuity is something that we really value, but it's so tricky and complex to get back to.
The chair has been too grand.
And I suppose the reality of the situation as well is that, with triaging patients before they're actually seen at surgery, you actually do work as well. Yes. You do telephone triage, and then you see the average on top. So you actually do more than you were doing pre-pandemic as well. And seeing more patients as well.
Thank you.
Can I
Thank you. Yes, I've got to move in 5 minutes, Chair. Thank you for that. Yes, I would certainly agree about face-to-face. I think it's still, particularly as I mentioned, at our Birmingham and Solihull, that predominantly I would imagine older age group would still prefer, because they don't like to use videos or maybe telephone. And I would imagine as well that with the GP reception, the staff, people have to remember that also that the staff are human beings, and it may be working, but they still have their concern when they're letting people in. So there is that certainly concern. And I'm thinking as well that maybe if they don't go to the doctor, they then go to the A&E, because they can't see the doctor, I'm going to go to the hospital instead, again putting pressure on their chair. And I do agree that I think that now that there's been an easy restriction, I think that people have now thought, oh well, that we can now go back to normal, and that is not. And I think there is that new model that needs to go forward. And one thing, as I said, at the Birmingham Solihull, which I've been doing for absolute years, and I do wonder why some people automatically go or ring up to get a doctor's appointment, because the first thing I do is, and again now, it's probably pressure on the pharmacies, but I will tend to go to the pharmacy and say, this, as I did the last time, and they actually said, because of my diabetes, looked at me and said, no, you do need to go to the doctor. And then I had a telephone call, then I had to go in and see the GP. So that's how it worked. But I still find, and that may be the communication, and that kind of links up with the Birmingham Solihull general practice operating model, which I think is quite good, from the green amber sites to the local vaccine centres and referral. But the bit that I thought was missed was about that network of working with the pharmacies. So that's the first step. Go to see the pharmacy, then go home, ring the doctor. You may get a telephone call, then the doctor will make the decision, yeah, I think you need to come in and see me. And I just look very welcome. And of course, we've talked about the COVID. We've now got the flu vaccines and the boosters. So that's putting more pressure on. And I really do sympathise with the GPs and everybody involved with that. And yes, it is a new model, Chair. And we've just got to get it in place for people to understand. And if they can start to sort of go to their pharmacy, which is something that you could have done years ago, not just think, oh, I'll just go to the doctor. That's my beef. Thank you.
Okay, to come back on the pharmacy point, so we
Yes.
are being encouraged to refer patients.
Yes, I'm sure you will, yes.
But working in a deprived area, patients get bounced back just because they can't afford to pay for some of the items. So what's actually happening is actually increasing our workload, speaking to or referring when they're coming back to us or having to deal with them. So I don't know if it's different in Solihull, but definitely in East Birmingham, it's not.
It's a challenge,
Yeah.
and where we are, we've got, there's actually 40 pharmacies Ferguson's, and PCNs in particular are growing relationships with community pharmacies and trying to utilise them on. But it really depends where you are. It's easier in Solihull, it's easier in Solihull, and that's the challenge. It sounds ideal, but it doesn't work.
Just very quickly, thank you, we talked about deprived areas, but am I right in thinking that if they go to the pharmacy, they would have to pay, and then they go to the doctor,
Yeah, get prescription.
and they get a prescription, and do they not have to pay anyway, or do they, depending on what they get?
So for children, they wouldn't have to pay, they go to the pharmacy.
Thank you, that's new for me, and thank you for that. Yeah, that's new for me, thank you, Chair, that's very helpful, the learning curve, thank you.
There is a community pharmacy scheme that's nationally being launched, and there are certain elements in that. It doesn't cover all disease areas or all prescribing that pharmacists to deliver on. And we have got a number of our general practices referring into that scheme, and the numbers are increasing. As part of that paper that was launched on Thursday night, there is a real push to get all of general practice to be part of that scheme by the 1st of December. So, but it's got someone's just sort of outlined, it's sort of what patients come back, it's being very clear what can be prescribed and what can't be prescribed and what costs and what doesn't cost. And I wouldn't be able to sit here and give you that detail now, but we'll provide you that detail.
And finally, I think that just shows that my lack of understanding, and I think that's very helpful for me to understand about deprived areas, about cost, etc. So I think I'd like to learn more from you, if I could, about that situation, because it is me thinking it's easy to go from pharmacy, and I've just had a nice little learning curve there, which I'm very grateful for. Thank you.
Can I just quickly come back?
Yes, please.
Regarding direction to private, we also get all the housing issues and banking issues.
Right.
Which had a huge impact during COVID. So I was on Monday working at Hartland, I was a beauty patient at 8 o'clock at night, and her spent half an hour on the phone, and her issue was housing. You know, so we get a significant number of calls regarding housing.
Well, certainly as my shadow portfolio, that's why I want to understand and learn more. So hopefully maybe through Gail, I can get some understanding of it, if I may. Thank you, Chair.
Thank you. Just to finish up asking two quick questions. In terms of the increased demand you mentioned, is that in terms of COVID or is that across the board? And secondly, in terms of the increased levels of aggression, is that on the telephone or is that actually experiencing that when you're physically in the practice?
Increased demand is possible. Our occupation rates few decades. COVID has put extra pressure on that. As I said 2 years ago, we well have had the same conversation about GP access, but it's like with the pandemic. The aggression has been actually in surgeries in Birmingham and actually taken out on reception staff. Understanding that windows broken, the like as well. Yeah, I was going to say the other elements were our social media and telephone as well. I've had abuse coming down the phone at me. I mean, partly I think we're dare I say, a little bit used to it in general practice over the years, rather sadly, but it's certainly possible.
The reason why that is because people feel they should be able to get an appointment with you, but you're not getting the answers they want, or was it difficult to say?
For me, it's access. A lot of it's actually about wanting things that we can't provide. Yeah. A lot of, for instance, just take COVID vaccinations or COVID passes or exemptions for masks, etc. We've had lots of those recently, which is simply not really our portfolio to do.
Waiting for hospital.
Yeah, waiting for hospital appointments in particular. I mean, it's not just primary care that doesn't do as much face to face. Hospitals do an awful lot of telephone appointments nowadays, consultants, and the waits are long, as we all know. So it's the frustration, I think, and you can see it. You can empathise with a lot of them. It becomes quite wary.
So in some ways you're a sounding board or the opportunity for people to ventilate their concerns about the way the NHS doesn't, in their perception, feel to provide some of the services
And I
they want.
suppose, I know we're talking about access, but I suppose GPs, we are accessible compared to all the other healthcare professionals. Even though everybody complains about not being able to see a GP, we are, isn't it? And that's when we get everybody vets at us because we are accessible.
Thank you for that. Councillor Hanson.
Yeah, that's got lots of questions. Accessibility then. I mean, I've always under the impression that I get 7 minutes. If I do get to the GP or I have done in the past, it's a 7-minute appointment. And I don't think I've really ever gone over 10 minutes. I mean, the history of me is pretty easy, I think. If I go for antibiotics or something pretty simple, it's quite a quick one, the history. So do you, I was interested in this about the housing situation, and I do get that. And people need to either lower their expectations about what you can specifically offer in that time frame, because it is about time efficiency. And I'm not saying that you're not a humane person and you're totally robotic, because you've got to, organise your own time. And, if I thought you were talking to somebody for 30 minutes every day in the situation, I probably wouldn't be very happy with you, if I'm perfectly honest. And I'm saying that in a very humane, cooperative, coexisting manner. It would, a person's situation is not my situation. It's not really right for me to comment on it. However, I was interested when you said it. So in that context, I'm going to comment on it. So the context you provided then, I thought I was under that impression that it's still a 7 to 10 minute, because I've often been asked, do I want a double appointment? So I would imagine with the time slot you've got within a given day, you've got to manage that time slot, just as a counsellor would in an advanced surgery. and say, look, I've got 10 people outside, I'm going to have to give you just 10 to 15 minutes. So, has that altered? I suppose my question around that is, has that massively altered because the expectations of I've been waiting 2 weeks to see you, and now I've got you, I'm going to give you my full attention, and you're going to hear me out. Are you having to say, which I would imagine is probably causing some aggression, is no, I've got to be specific because, as you can understand. And also, I'm just interested in the websites that you've got. Are you sort of saying to people that may access online, please bear with us. You are valuable to us, but the situation is with COVID pandemic and a high number and increase. We are working through this and we aim to deal with you on a one-to-one basis. I just wondered what that comms was. So it's a lot to take in, I'm sorry. And very quickly, the figure was thrown out earlier about 1,750, which was a workable figure. What would be the figure around now? And I suppose it differs between GP surgeries based on population, because I was looking at Longbridge and West Dean, and I know I've got about 18,000 in my ward that I represent. Obviously, that's different lower for households, but a population over 18 is a lot, and I just wondered the GP surgeries in my ward, how that number, 1,700, is floating for my ward. Can we get some data around this? I actually want some data around that. Please.
Would we normally get that? Yeah.
Thank you, Chair.
You can provide it.
We'll look into it.
We
I'll tell you why.
we're trying to get that kind of data, as you say, it's there's data and data, but.
Okay, I don't want to put extra workload on it, because that's not what we're here for.
We do have data on the amount of GPs, different GPs, how many patients, etc. So we can get some proxies of that, and it does vary from location to location. And we've got to understand the issue. So I quite agree. You know, it would be helpful to have that data. We've got proxies for that we can.
That would be really helpful, and I hope I haven't offended you in that earlier. It's just that we talk about, as counsellors, we get a whole mix.
Yeah, no, not at all. I mean, she was the last patient on my call anyway, so there's nobody waiting after her. So,
yeah, I mean, I had a letter last night that was sort of so distraught from a constituent. It was a medical comment, very deep. Sort of, I won't go into the case itself, but it makes you think. It's the last one I read at night, it was 9 o'clock, and I thought, goodness, the last one you get is sort of, do you give any more or you don't? But I'm just conscious, being a public meeting, people would hear that and think, well, actually, my leg felt like it was dropping off. I don't want to hear you say that. My leg felt like it was dropping off and I would have needed to see you. So I think it's expectation of the public.
yeah, she was my last patient, but I think general practice, we are pragmatic, isn't it? Even though we say 10 minutes, some patients may have 10 minutes, some patients do need longer. They're more rather than more complex needs. So you just have to adjust your time. You know, some patients may take less than 10 minutes, some will take longer. So I don't think it's clear cut.
No, I totally agree. I mean, this is one of
it's the human kind of a relationship you deal with unwell people. You just have to make that assessment as you go along. And unfortunately, some patients do take longer.
I was going to say that there's a lot of hidden work happens in primary care, not just by GP nurses and reception staff have been gone out and helped us with visits and things of that nature, not to assess them, but support people. But yeah, you can have a very simple ear infection, it's 5 to 10 minutes, you know, but you still might spend a bit of time with it. But then the next person, for instance, yesterday, you can spend 40, 50 minutes with someone with a diagnosis of cancer. And that's a lot of the hidden work. That's not because on our appointment screens that you can be at 7 or 8 o'clock at night, and the GPs going home. And yeah, so that's how we've always worked. And I think we're just finding that we can't work like that anymore, which is.
And I wouldn't want to just limit 10 minutes with some patients and say 10 minutes is like, there you go. I don't think we want to work like that. You know, we value our relationships with patients, and if the patient needs more time, and you know, unfortunately due to underfunding and all that kind of stuff, it restricts it. But you know, that's why we enjoy general practice, and that's important to us. So you just have to readjust it on a daily basis.
Thank you. Councillor, the last one.
Thank you, Chair. Very quickly, I think that because you mentioned your GP in the East Side of Birmingham, I'm also a city councillor concerned with Birmingham. So I believe that from my experience in the last few years, it's been I've learned that it's very different at the east side of Birmingham. Things work very, very differently, and the demand is very high. And because of the area and the way that the area and the side of Birmingham, which is very densely populated, and the demand is, it's very, very difficult as a council to explain to residents what the limitations that we have, the resources that we have, and there's increased pressures. And I think that tells them that not just yourself, but all GPs across the city and the country have worked absolutely phenomenal, and they're trying to back. So I just wanted to say that it's really good, and I appreciate that. Sometimes when I speak to residents, and I know you mentioned half an hour speaking to a patient about a housing issue, I might get a resident calling me about a GP issue. Because they just don't know who they should be directing their problems at. So sometimes I get caught up in that role as well, where I'm trying to get them to contact their GP or contact another service to direct them the right way. But what happens is very easily, they just want to stay on the phone because they've got you on that phone, and they just want to be like, right, okay, you're our GP, you can do it because you're somebody in authority. But it's not always like that. And I think that these housing issues and things like that are sort of, this is the foundations, I think, that then lead to the stresses and all the other things, the health issues. So I think that patients and residents, even myself, then feel that they need to mention this and sometimes the GP could do something, have an influence over this housing issue, and make it go away or make things better or get them rehoused somehow. So I totally appreciate what you said, but I understand from a council's perspective as well, because those who are struggling, I mean myself, I've been struggling to get my father an appointment for a very, very long time. Finally got an appointment, but again, it's quite limited, and if it goes over the 10 minutes, it's like, right, okay, this is just an appointment where we need to have to sort of see just one issue or maybe two key issues, not a list of issues. So sometimes, again, seeing various different GPs would mean that we are then having to spend 10 minutes of our time just repeating our history, especially if someone that has complex health issues or health needs. I think part of the plan that you have, I just want to add, if it's possible at all, to perhaps have GPs who read up the history as opposed to, or make sure that the previous GP that the patient's seen has made detailed notes and read up about the patient, as opposed to when the patient arrives, then they go to like a long history, which can then take up a lot of the time, which then impacts the day and the following patient and the patient after that. So that would be quite helpful, and whether it's at all possible, and it can be quite difficult to be able to, if the patient needs a follow-on appointment, when they go to see the doctor or the GP, whether they can perhaps book that in, because then I think that will then relieve the pressures of the phone lines and the receptionist and so on. So I think that would be something that possibly, if you could perhaps think about that when you have put that plan together, I think that may be beneficial, because I certainly think that with my personal experience, just very quickly, my daughter, she's, because of lockdown, couldn't access the nursery space, and she was very looked after at home, at that home, working from home. So even though we are public members, our class as key workers, and my husband's also a key worker, I didn't want to send her out to the nursery, because I felt that there's other key workers that would benefit more from that nursery space. So she sort of fallen behind, unfortunately, in terms of speaking and development. But she's sort of up to speed now. But at that time, there was a GP, a junior GP, who then booked on follow-up appointments after a few weeks, and did that. So that was very, very helpful, as opposed to moving it up constantly, trying to get that appointment for my daughter. So I think that was quite, just as a personal experience, that was very, very helpful. Hence the reason my suggestion. But yeah, I think it's very, very important that we keep the times sort of limited, and perhaps maybe highlight at the beginning of the call that, you have X amount of time. That may help, especially for residents or patients that are living in the east side of Birmingham. I can only speak for them, because of course when I speak to them, I say, right, okay, I've got 10 minutes to speak to you, or I've got 20 minutes to speak to you, or just wanted to ask them to highlight the key issues, so we know how much time can be allocated to them. So, yeah, it can be a challenge, but, yeah, we'll do a great job.
Okay, thanks very much for that. I appreciate that, and I appreciate your comment. I appreciate you, GPs, for your time and your comments. It's been really, really valuable for myself and for the community as a whole. So thank you.
Chair, can I make a comment? If any of the councillors or committee would like to go and do some shadowing in general practice, so they can really see how things are in their constituency, I'm sure we could accommodate that and support that. I mean,
A number of the members, have had to go, unfortunately, so I'll get Mel to make a note of that. We can circulate that around the members and then possibly get back to you directly. Lisa? Yeah.
Just wanted to offer that so that then, people can see firsthand how difficult it is, and then help us with messaging to patients as well. Thank you.
Thank you for making the offer.
Thank you.
Yeah, can I just say, what I've found over the years is, the GP practice, the GP and the relationship between the patients is deteriorating. Over the years, and it's getting worse and worse. And there's no attention or care being shown by the GPs when you go and see them. And you're lucky if you get 2 to 3 minutes. And I've been trying to, over the years, I'm lucky to have a good health and then good health, still do. And when I need a GP practice appointment, I struggle. I've been trying to make an appointment from last week, never got one. Then on last Friday, I went to my practice rather than ringing. And every time you go there, ring in the afternoon. When you do that, fully booked. Ring in the morning. When you do that, fully booked. And I tried to explain I need to see the GP and the member of staff wasn't interested. And I said, I need, GP can give me a ring. I can speak to her, and the attitude shown by that individual was so bad and arrogant. If that individual was working for me, I would have sacked that individual there and then and bear the consequences, because
I should take up the offer and shadow your GP.
Yes, it did. Thank you very much.
Thank you. Shall we, we're a bit over time, so we press on with the, pardon?
Massive.
We are, and I kept it to time. Right, so the work programme for October 21, the Birmingham Sandford Joint Hospital is been confirmed to take place on Thursday, Sandford, very people involved on that. And the next Birmingham Solihull Joint Hospital now been arranged to take place on Thursday, the 2nd of December at 2 o'clock, and we'll be hosting that meeting here. If any members want to have a discussion on the work programme, we can do. I presume members may want to press on to do other things now. Request for call-ins. Do we have any? No. Any other urgent business? No. Authority to act between meetings? Great. And then we will be meeting with the board in November. So thank you all for today. I appreciate it.
Thank you.